Hello and welcome to the 2015 CROI convention here in Seattle, Washington. Today we're going to be talking about lung cancer and HIV, which is a really fascinating and important field that I'm just learning about. Today with me we have Keri Althoff.
Althoff, correct.
Althoff, thank you, from Johns Hopkins University. And we have Keith Sigel from the Icahn School of Medicine at Mount Sinai, and also Elizabeth Yanik from the National Cancer Institute. We're really glad that you're here with us because our viewership wants to know about cancer and HIV, and especially in terms of smoking, aging, and we'll get some details about the work and the process flow and how you make decisions about what's important and what you're going to frame your research topics to be about. So maybe we'll start with Keri, and if you can give us a little bit of background about yourself, and then tell us a little bit about smoking in HIV and lung cancer.
Sounds good. So I'm Keri Althoff from Johns Hopkins School of Public Health, the Bloomberg School of Public Health, and I'm an assistant professor there. My research interest is specifically aging with HIV. So it encompasses a lot of different age-related conditions that we're seeing become more and more prevalent in HIV-infected individuals who are aging with HIV. I also investigate the quality of HIV care domestically. I work in large HIV cohorts, as well as the collaboration of many cohorts called the NA-Cohort, the North American AIDS Cohort Collaboration on Research and Design. So very fun projects. And recently I've been investigating a number of different cancers, as well as myocardial infarctions or heart attacks, end-stage renal disease, end-stage liver disease. But what we're finding with cancer is that we know smoking is a risk factor for a number of different cancers. And we also know that smoking is very high prevalent in HIV-infected populations, and that the duration of smoking actually tends to be longer as compared to the general population, which means people with HIV start smoking at a younger age and therefore smoke for a longer time period. But we're also seeing now individuals with interest and success in smoking cessation in the HIV community, which is very exciting for us because we know now that individuals are going to live a long time successfully on antiretroviral therapy. We have to do things to protect their long-term health. And smoking is one of those things that we know, regardless of whether or not you have HIV, damages your long-term health. So smoking specifically in lung cancer, one of the projects I've been working on is looking at how different risk factors for cancers contribute to the likelihood of having that outcome. So that's one of the studies I've recently been working on that's highlighted at this conference.
And can you tell us a little bit about how they do contribute?
So I looked at a number of risk factors, smoking being the most quote-unquote traditional risk factor that we measured within. This is within the NA-Cohort, the North American AIDS Cohort Collaboration on Research and Design. And we looked at whether or not an individual was an ever or never smoker. The data that we get from the NA-Cohort is a little bit more coarse in terms of we aren't able to tell exactly when someone may start and stop across all the different cohorts. So we just took this measure of whether or not an individual was ever a smoker, and we put that into a model with a number of other HIV-related risk factors. So CD4 count, viral load, history of clinical AIDS, as well as other risk factors like hepatitis C or hepatitis B. And then we looked at all non-AIDS defining cancers. And we said, okay, amongst these different risk factors, if we could intervene on one of them, where would be our biggest bang for the buck in terms of avoiding cancers? And we found that it is within smoking. If we were able to take all of those ever smokers and actually make them never smokers, we would prevent almost 40% of non-AIDS defining cancers. And that's compared to if we were to essentially keep a CD4 count above 200 or keep a suppressed viral load, we're only going to prevent about 8% of those cancers. And then when we took lung cancer out of our outcome, because we know the close relationship between smoking and lung cancer, we take that out and we see a small decrease in the proportion of cancers that we could avoid, but only a small, about 8 percentage points. So we're still talking more than 30% of non-AIDS defining cancers could be prevented if we took all of those ever smokers and classified their risk as never smoking. But that's a big charge. I mean, that's an intervention at an adolescent age, really,
right,
to stop smoking before it starts. in individuals, not just with HIV, but individuals who are at risk for HIV. So it's a big charge to do that. We'd like to refine our analyses further to look at what types of, or the proportion that we could prevent in terms of cancers if we had an individual who wanted to stop smoking. And at the time in their life, after the duration of smoking, taking all those things into account, how many cancers could we prevent if individuals could just cease smoking. So the idea here is that smoking is a very strong contributor to lung cancer, as we know, and to all non-AIDS defining cancers. And so if we want to prevent cancers, this is a very critical point for intervention.
Sure, and the challenge becomes, how do you get people to have behavior change at such a young age? Do you have any theories about why you're finding that the HIV population has this higher rate of smoking?
You know, there have been a lot of hypotheses as to why it is, but when I go to conferences and I hear individuals with HIV discuss smoking, it becomes clear to me that smoking isn't just a behavior. It's oftentimes related to mental health. I've heard people say, well, my depression is easier to manage when I'm able to smoke. And different things are easier to manage when you're able to smoke. So I think it's not just a behavior, and we have to be very careful about that. And think critically about those interventions and have more research about exactly what smoking is in the HIV-infected population in order to best intervene.
Yeah. And well, let me ask you, Elizabeth, since you were working on these developments of cancer in aging populations, and so do you have any insight on this, or how could this behavior and dependence of some kind on smoking at a young age for HIV populations be playing into your research? And can you also give us a little background about your research?
Sure. So I'm Liz Yanik. I work at the National Cancer Institute, and I work broadly on looking at cancer in immunosuppressed populations, and so HIV and cancer is a large area of my work. The study that I'll be presenting at this conference is actually looking at cancer risk in the Medicare population. So this is people 65 years of age and older in the United States. And this is sort of an interesting project because only recently have there really been enough people that you can get a good look at the cancer incidence in this population. But of course we know this population is growing, so it's going to become more and more important over time. And the study we did when we looked at the different cancer types, it was interesting because a lot of the ones that are very frequent are the ones that are associated with aging, some of which aren't associated with HIV, such as prostate cancer, colorectal cancer, and women breast cancer. And then lung cancer is one of these ones where you both see an increase with HIV and you also see an increase with aging. And so you see a lot of lung cancer in this population. It was the second most common cancer overall, and the most common cancer we saw diagnosed in women. And so I think there you're sort of seeing the manifestation of both the aging effect and the effect of the tobacco use in the HIV population.
And it's really fascinating that these populations will come from such dramatic different environments. You know, if you're looking at Medicare data right now for people who are 65 and older, the world that they grew up in was so dramatically different than the world we have now. It's going to be an interesting challenge to figure out how you can attack maybe Gen Z and Gen Y behavior change, if that's what you're going to have to do to get them at such an early age. Any comments on how the culture and technologic changes are affecting?
Well, I think one interesting thing is that the immunologic mix of our HIV-infected patients has been changing over time, and we're seeing the results of a lot of immune damage that happened 10 years ago, and I think that the cancer environment is going to. One thing that's going to stay relatively constant is smoking. I mean, obviously rates are going to go down, but a lot of the like you were saying, Keri, there is a small component of immunologic damage and immune dysregulation that contributes to this increase in cancer risk. And I think a lot of that damage happened sort of not in the early days, but sort of in the early 2000s when we still weren't, getting such tight control with people. So.
When you say control, do you mean controlling their viral load?
Yeah, virologic control. If you just think, 10 years ago, there were situations where we might not start a patient on treatment until they hit a CD4 count of 200. Nowadays, we see, we treat almost everybody. I think a lot of the cancer-related research and the cardiovascular research has really helped to push the threshold where we initiate treatment. Because what we're finding, and that segues nicely into what I'm presenting here.
Yeah.
I'm Keith Sigel. I'm an assistant professor at the Icahn School of Medicine at Mount Sinai. I treat HIV, and I've been very interested in lung cancer for about 7 years in the HIV-infected population. And the work I'm presenting looks at the contribution of low CD4 count, cumulative low CD4 count, on lung cancer risk after accounting for smoking. But one sort of thing on the side that I found that was very interesting was looking at the ratio of CD4 to CD8 and the relationship of that to lung cancer risk. And why that's interesting is, in patients that, they have an initial CD4 decline and a CD8 rise, so you have a low CD4-8 ratio. And some people get on treatment and their ratios normalize, and some people's ratios don't normalize, and we think it represents this inflammatory state. And we've been seeing a lot about that at CROI this year. And what I found is that a persistently low CD4-CD8 ratio was an independent risk factor for lung cancer after accounting for smoking. So I think that, going back to what I was saying earlier, I think we're still seeing a lot of sequelae of less tight viral control that was sort of more prevalent in the past, and so I think that the cancer incidence and cancer risk in the HIV infected population is going to be a very moving target over the next 10 years. We're going to see a lot of changes.
And when you have this ratio of CD4 to CD8, is it possible that it's correlated also with other forms of late life cancers?
That's a great question. That's something that's the next thing I actually would like to look at now that I feel like I've sort of perfected a technique. I did this work with the veterans aging cohort, which is actually one of the cohorts that contributes to NA Accord. Lung cancer is a unique cancer. We learn more and more that T cells play a very important role in the development of lung cancer, and that's why a lot of the new really exciting treatments for lung cancer activate T cells. So, whether we're going to find signals with other cancers is not clear. But I think it helps to illustrate the uniqueness of the relationship between HIV, its effect on T cells, and lung cancer. They're so intricately linked. And smoking. Smoking has effects on T cell count. It has effects on CD4-CD8 ratio. So there's a lot of things at play.
And I think just to pick up on that, the idea of there is a potential cohort effect that we're seeing with some of these outcomes that we just have to be aware of in our research, and that's why the monitoring is so important. Just because right now, we may be seeing something now, it may not be there in 5 years or 10 years, because individuals, for example, today, who are initiating treatment at higher CD4 counts, who may not have an AIDS-defining illness for years and years and years and years, those individuals have a different immunologic kind of lifespan, right? Their immunology is different over the course of their lifespan as compared to people who were fortunate enough to survive to effective treatment. So I think this is a very important point. In our research, we see that a clinical AIDS diagnosis is a very strong indicator of a lot of these age-related outcomes, which to me it's very similar. It says, there's this point kind of maybe of no return for an immune system where it gets damaged enough that the time after that may be different for somebody as compared to someone who never had that kind of moment where their immune system was so damaged. So I think those types of things are things we constantly keep in the back of our minds as we continue our research in age-related diseases, knowing that these are age-related diseases, and without a doubt, as Keith said, it's a moving target.
And one thing that I found very consistently is that viral suppression does not seem to be related to lung cancer incidence, at least. Which again, I think harkens back to the idea that there's at least immunologic damage that's happening from sort of probably later treatment initiation. So I think that we're headed, as we're treating people earlier and catching people earlier, we're headed to a situation where I think the cancer risks are going to more reflect the general population and reflect sort of, lifestyle variables like smoking environmental exposures and things like that.
Right. And viral load, I think, is a little bit of a slippery fish in these studies, primarily because CD4 is a much more constant marker as compared to viral load, which can fluctuate very quickly with lack of adherence to treatment, et cetera. And so we have to remember that we are always restricted by our measurement, right? Whereas CD4 is a little more forgiving of gaps, wider gaps in measurement, viral load is not. So if we're not fully capturing all those blips and different things, we may see no effect when an effect could be there. Regardless, we know that the way to,
Sounds like you're disagreeing with me.
A little bit. I'm just not ready to say viral load doesn't have an effect yet. I'm not convinced of that yet, primarily because of the measurement issues that we see in viral load. And there are new measures like viral load copies and different things that we can attempt to employ, but it really does boil down to the fact that how frequently viral loads are measured and whether or not we're really capturing what happened with viral load in the time span between one viral load measured to the next.
Sure.
I'm not convinced we are all the time.
Yeah. Well, we should discuss that.
Yes.
I'd like to tell you how I did it.
Yes, I'd love to discuss. But regardless, I think, the message is consistent that regardless of whether you're trying to suppress viral load and maybe decrease inflammation through that pathway, or you're trying to stabilize and improve a CD4 count by starting, ART at a higher CD4, I think the message is consistent that these treatments work and that getting on these treatments and preserving your immune health and status, and that does mean viral control, is absolutely essential to healthy aging with HIV.
And that probably the most cost-effective thing overall is smoking cessation.
Yes.
For preventing cancer
Yes.
in this population and any population.
Exactly.
That's right. There's no different, between HIV infected and non-infected when it comes to smoking, except maybe that it could be synergistic. So it's even more important for smoking cessation.
And I think those probably go together, that if you can sort of start people on treatment earlier, they're dealing with less of the acute problems. It's easier to focus on something like tobacco cessation because you don't have so many sort of immediate issues that are at play.
Yeah, completely agree.
It's such an important message that we've been hearing here at CROI a lot about. I went to a community meeting and they were talking about what the rate of people who are community service members, who the intimate knowledge that they have or don't have of the technical functioning of the antiretrovirals and belief in the science that's kind of waning out there in the community sometimes. And that's why meetings like this and discussions like this are so important, getting it out there to the public and telling them and reminding them, don't smoke and use your antiretrovirals.
Right.
Yeah. No, I mean, whenever I start a patient on treatment, I'm biased, but I think about, starting early and trying to avoid some of these things that I think really lead to a lot of complications.
Yeah. Okay, well, I think that's all the time that we have, and thank you so much for coming in and talking to us. This was really illuminating.
Thank you,
Great,
Chris.
thank you
a lot.
for inviting us.